Now, the first and the most important question which they'll ask in your NEETPG exam is a child with ambiguous genitalia. So you may have a child who has a phallus or a penis-like structure with absent testis. So you cannot palpate testis here. And remember, ambiguous genitalia can be anything from just, fused labia to a good sized normal looking penis with, there are no testis, no palpable testis. That's called ambiguous genitalia. And remember, CAH, congenital adrenal hyperplasia, is the most common cause of a female pseudo-hermaphrodite. So remember, this question also came in NEETPG once. It's the most common cause of a female pseudo-hermaphrodite. Okay, and remember 90%. So all of you, please remember 90% of CAH is a block here. Okay, so 90%, I would say 90% is a block here. Okay, 21 hydroxylase deficiency. So 90% is a block here, 21 hydroxylase deficiency. Okay, so as you can see here, aldosterone is not formed, cortisol is not formed. Okay, and there is excess of testosterone. Okay, and there is excess of testosterone. So if aldosterone is not formed, what will happen? Sodium will be less, potassium will be high, and this child will be in shock. Addison's crisis, which is also called an acute adrenal insufficiency. So remember, all of you, 70% of CAH presents like this in a classic salt wasting crisis. That's a classic salt wasting crisis. That's a classic presentation of CAH. Okay, so that's the most important point here. So coming to this first question, so if you have a child with ambiguous genitalia who classically presents to you with the Addison's crisis or an acute adrenal insufficiency, think about the classic form, the 21 hydroxylase deficiency variety of CAH. Okay, now remember, all of you, testosterone is high. Now because of excess of testosterone, there is clitoral hypertrophy. So it looks like a penis. Okay, so it looks like a penis. Now, because the cortisol is not there, the ACTH increases. And because of the rise in ACTH, what happens is that there is pigmentation of the labia. So labia look like scrotum. The labia are pigmented like scrotum. Okay. Boys get precocious puberty and girls get ambiguous genitalia. Now remember, the diagnostic test for CAH is 17-hydroxyprogesterone. This is the diagnostic test of choice called 17-hydroxyprogesterone. Okay. So the treatment of a crisis, this question also they will definitely ask you. The treatment of crisis is to give them normal saline with hydrocortisone and fludrocortisone. So treatment is giving them normal saline and hydrocortisone and fludrocortisone. Okay. Let's go to the next question. Now, a very important question for your NEETPG is a child with calcifications in the brain. Okay. Now, remember that in fact, the most common cause of intracranial calcification, the most common torch infection causing intracranial calcifications is toxoplasmosis. That's toxoplasmosis. Now, what is classic about toxoplasmosis is that these calcifications, all of you, the calcification which you can see here, their site is in the caudate nucleus, choroid plexus, caudate nucleus, choroid plexus, subependyma, caudate nucleus, choroid plexus, subependyma, and they can block the aqueduct. So remember, the calcifications in toxoplasmosis can block the aqueduct. Okay, so it can cause hydrocephalus. So that's very important, that in toxoplasmosis you can see hydrocephalus because the calcifications can block the aqueduct. Of course, the source is cats, toxoplasmosis. The main source is cats. Man is an incidental host. Okay. So remember, almost 25 to 50% of toxoplasmosis have intracranial calcifications. Now, hydrocephalus is specific for toxoplasmosis. This question came in your NEETPG. The drug of choice for toxoplasmosis is pyrimethamine with sulfadiazine. Now remember everyone, you can even have CMV as a cause of intracranial calcifications. But remember that the calcifications in CMV are classically periventricular. So can you see the difference here? In CMV, the calcifications are periventricular. Let's go to the next question. In the newborn screening, you have a baby who has some abnormality. Now, how do you diagnose hypothyroidism in a newborn? Now, remember congenital hypothyroidism. So please remember, all of you, congenital hypothyroid is the most common preventable cause of mental retardation. Congenital hypothyroidism is the most common cause of preventable mental retardation. These babies have hypotonia, hypothermia, umbilical hernia, constipation. So hypothermia, I said hypothermia, and they have umbilical hernia, prolongation of jaundice, hypotonia. And remember that these babies can later in their life can have mental retardation. Okay, so all of you, every baby in the world should get a TSH and a T4 almost after 72 hours of life. So according to the American Academy of Pediatrics, you need to get a TSH and a T4 after 72 hours of life. So this interval after 72 hours to 6 days is the best time interval to look for congenital hypothyroidism. It's preventable because you can supplement thyroxine in these babies. Remember all of you, 85%. So please remember all of you, 85% of congenital hypothyroidism is agenesis or dysgenesis of the thyroid gland. 85% of congenital hypothyroidism is agenesis or dysgenesis of the thyroid gland. If you look at the X-ray, now remember all of you, thyroxine is important for bone maturation. It's important for bone maturation. So in a newborn, so on your left is an X-ray of a newborn. And what can you see here is that the lower femur epiphysis is absent. So all of us know from a forensic medicine that in a term baby, the lower femoral epiphysis appears in a term baby. Now the bone is not ossified. I said thyroxine is important for bone maturation. So the lower femur is, the epiphysis is absent. And on your right, what you can see here is that you can see the epiphyseal dysgenesis of the humeral head. So abnormal epiphysis. So this is the answer to our question, that in congenital hypothyroidism, you can have epiphyseal dysgenesis, especially of the humeral head, So this may diagnose, but remember, you need to do a TSH before that because we need to supplement them with early thyroxine. Coming to the next question, you have a baby who has suddenly come to you in shock. Now, what is your differential diagnosis in a baby who comes to you with a shock in the first week of life? Infections? And the second differential can be that the ductus arteriosus closed. Now, what is ductus arteriosus? It's a channel, all of you, which joins the pulmonary artery to the aorta. So as you can see here, it's a channel which joins the pulmonary artery to the aorta like this. Okay, like this. So now, when does ductus arteriosus close? Let's talk about when does ductus arteriosus close. So all of you, please remember that the ductus arteriosus closes physiologically and anatomically. So there are two closures, the physiological closure, and the anatomical closure. Now physiologically, remember, it basically vasoconstricts. So remember, it vasoconstricts within the first 10 to 15 hours of life. So according to the Nelson's textbook, it vasoconstricts within the first 10 to 15 hours of life because of oxygen. So remember, ductus arteriosus vasoconstricts within the first 10 to 15 hours of life because of oxygen. Now anatomically, the lumen closes forever within the first 10 to 21 days of life. So anatomically, the lumen closes forever within the first 10 to 21 days of life. Now remember, let's look at a child, all of you, who has a left-sided problem. Let's look at a child who has a left-sided heart problem. For example, suppose he has hypoplasia of the left heart. Okay, left heart is hypoplastic, hypoplasia of the left heart. Or suppose a child has critical aortic stenosis. Okay, hypoplastic left heart, critical aortic stenosis, और a pre-ductal coarctation, ductus से पहले coarctation, pre-ductal coarctation. So all of you, I'll give you 4 examples. So just remember these 4 examples. So let's talk about a child, all of you, who has, I said number 1, hypoplasia, hypoplastic left heart. Okay, hypoplastic left heart. Or who has a critical stenosis of the aortic valve. Or suppose he has a pre-ductal, before the ductus, he has a coarctation of aorta. Before the ductus, he has coarctation of aorta. It is also called interrupted aortic arch. That's also called interrupted aortic arch. Interrupted aortic arch. So there is interruption in the aortic arch before the ductus. Now what will happen, all of you? Let's talk about now what will happen. Now what will happen here is, all of you, now before birth, everything was fine. Before birth, everything was fine here. Okay. So there was ductus arteriosus, everything was going on fine. Now he's born, all of you. Now he's born. Now how will his blood go to the system X? How will his blood go to the system X? So till the ductus is open, all of you, the systemic blood flow will be provided by the ductus arteriosus. So all of you, in the children who have left-sided problems, the ductus arteriosus provides the systemic blood flow. It provides the systemic blood flow. जब तक ductus खुला है, systemic को blood मिल रहा है. And as soon as ductus arteriosus closes, systemic को blood नहीं मिल रहा. So there is no blood to the systemics. So this child is ductal dependent. As soon as the ductus arteriosus closes, there is no systemic blood flow. So this child presents in shock as soon as the ductus arteriosus closes. So in the emergency, all of you, we will give him continuous prostaglandin infusion. So all of you remember, in the first week of life, if you ever have a child who comes to you in shock or central cyanosis, we give him prostaglandin infusion, which is also called alprostadil, in the emergency to keep the ductus arteriosus open. Okay, all of you. So if we come back to this question, in a child who came to you with shock in the first week of life, I would say my differentials are hypoplasia of the left heart, a critical aortic stenosis, or a pre-ductal coarctation of aorta. And my next step is to give him prostaglandin infusion. Let's talk about vocabulary. When can a child speak around 50 to 100 words? Around 2 years. So remember, if we talk about vocabulary of a child, at 15 months, a child has a vocabulary of around 4 to 5 words. At 18 months, a child can speak around 10 words. And at 2 years, suddenly his vocabulary increases to almost 50 to 100 words. And this is the time when he would also speak a 2-word phrase. Okay, 2-word phrase, jaise pad lo. Okay, so 2-word phrase, all of you. Okay, like don't laugh, don't smile. So 2-word phrases is also at 2 years. So remember, vocabulary of around 50 to 100 words is at 2 years. Now all of you, here is a child, all of you, who comes to you with polydipsia, polyuria, okay, and his urine specific gravity is less, sodium is high. So this looks like, let's talk about approach. What is the approach to a child who comes to you with polyuria and polydipsia? So all of you, let's talk about what is the approach to a child who comes to you with polyuria and polydipsia. So all of you, first thing is do a blood glucose. As all of you know, a random blood glucose more than 200 milligrams per deciliter, a random blood glucose more than 200 milligrams per deciliter, and or a fasting blood sugar more than 126 is called diabetes mellitus. All of you know that's called diabetes mellitus. Simple. So first of all of you, please rule out diabetes mellitus. Now, if diabetes mellitus is not there, all of you, my next step is to do a blood gas, a venous or arterial blood gas, anything is fine, and sodium and potassium. Okay, all of you, venous blood gas or arterial, any of them is fine, and we look at sodium and potassium. Now, all of you, there are 3 possibilities. Let's talk about the 3 possibilities. The first possibility is there is hyperchloremic, hypokalemic, normal anion gap metabolic acidosis. Hyperchloremic, hypokalemic, normal anion gap metabolic acidosis. Now all of you, this is called RTA, renal tubular acidosis, has a hypokalemic, hyperchloremic, normal anion gap metabolic acidosis. Okay, all of you. Now other can be hypokalemic, hypochloremic, metabolic alkalosis. Now remember, hypokalemic, metabolic alkalosis with polyuria polydipsia is seen in Bartter syndrome and Gitelman syndrome. Bartter and Gitelman. So how do we differentiate? Barter's is severe, presents very early. Okay, Gitelman's presents late. Okay, maybe I can write 2-3 things for you here. Bartter syndrome presents early, is very severe. Okay, very commonly Barter's has hypercalciuria, increased calcium excretion, which can cause nephrocalcinosis. So it can cause medullary nephrocalcinosis. Okay, that's very important. On the other hand, Gitelman presents late. These children are, well-thriving children, a well-thriving adolescent. They have less calcium excretion, hypocalciuria and hypomagnesemia. So remember, in Gitelman syndrome, magnesium levels are low. All of Gitelmans have hypomagnesemia. That's very important. Coming back to our approach. Now on your right side, everything can be normal. Sodium is normal, blood gas is normal. Now all of you, this can be of 2 types. Either it's a psychogenic polydipsia or a diabetes insipidus. Psychogenic polydipsia or diabetes insipidus. Now, how can we differentiate psychogenic from diabetes insipidus? By a water deprivation. How can you differentiate psychogenic from DI? Water deprivation. Because if you do water deprivation, in psychogenic, the urine osmolality will double. Okay, if you don't give him water, urine will become concentrated. So urine osmolality will double in psychogenic. Okay. In DI, it will remain the same. Now, DI is of two types, central and nephrogenic. So DI is of two types, central versus the typical mostly 90% of nephrogenic. Even right now, I'm seeing a patient who has nephrogenic DI who came to me from Iraq. So 90% of nephrogenic is X-linked. Okay. So how do we differentiate them? By a vasopressin challenge. Now, which child will respond to vasopressin? Which child will respond to vasopressin? Central, जिसमें pituitary की problem है. So on giving vasopressin in central diabetes insipidus, urine osmolality doubles. On giving vasopressin in central DI, urine will become concentrated. Now here in this question, it's a typical boy in which on giving vasopressin, urine osmolality did not improve. So all of you, this question which I asked you was a typical nephrogenic diabetes insipidus. And remember, the drug of choice is hydrochlorothiazide plus amiloride to prevent hypokalemia. Yes, thiazides paradoxically reduce the polyuria in these patients. So in nephrogenic DI, thiazides paradoxically reduce the urine output here. Let's talk about the next point. A boy around 1 year old comes to you with fever, strawberry tongue, lymph node, rash. So he has a typical Kawasaki disease. Now remember all of you, Kawasaki is a clinical diagnosis. There is no investigation of choice. And in fact, nowadays in COVID-19, we see a lot of multisystemic inflammatory syndrome in children with COVID. That's called MISC. It's called multisystemic inflammatory syndrome in children with COVID. It looks just like Kawasaki disease. We are seeing a lot of these children. Now, way back in 1967, Dr. Kawasaki, he made a diagram like this, exactly like this. He had a pencil and he made all of these things. So this is just a reproduction of what Dr. Kawasaki taught in 1967, almost 50 years back. And all of you know Dr. Kawasaki expired in June this year. So he showed that Kawasaki disease in the acute phase, a child can have fever, arthritis. Myocarditis is seen in the acute phase, remember. Aneurysms and desquamation are usually seen in the 2nd to 3rd week of illness. So remember, aneurysms are usually seen late. So all of you, I am from North India, and every day of my life in our ICUs, we are seeing, this is COVID era, and we see a lot of children with MISC and myocardial failure. They just look like Kawasaki and they die. If we have got echocardiographies and the ejection fraction is 10% and they die. So in the acute phase, child can have red palms and soles, cervical lymphadenopathy, thrombocytosis. Okay. Now why are we talking about Kawasaki? Because this is the most common acquired heart disease in the developed world, in the US and Japan. In the US and Japan. Okay. And why are we talking about this? Because Kawasaki, on your screen you can see a coronary angiography where these children can have aneurysms. Okay, so 20 to 25%, remember all of you, 20 to 25% of children with Kawasaki's get Coronary artery aneurysms, 20 to 25% in the second to third week of life. If you give IVIG, intravenous immunoglobulin, then less than 5%. So if you give IVIG, less than 5% of children get aneurysms. So the drug of choice is IVIG with high dose aspirin. Now remember, the case definition is fever at least 5 days and any 4 of these 5. Changes in the extremities, edema of the palms and soles, edema of hands and feet, peeling of the fingers, toes, a rash, conjunctival inflammation, strawberry tongue, unilateral cervical lymph node. So that's the classic of Kawasaki disease. So remember, it's a clinical diagnosis and we have to give early, within the acute phase, we have to give IVIG, 2 gram per kg of IVIG in the acute phase. Now, this question, in fact, the next question came in your NEETPG last year, a triad of eczema, thrombocytopenia, and immunodeficiency is Wiskott-Eldridge syndrome. So remember, Wiskott-Eldridge is an X-linked recessive syndrome. It's a boy here, all of you. You can see it's a boy with a classic triad of eczema, thrombocytopenia, and immunodeficiency. Remember, they have small platelets, that's called microthrombocytes in Wiskott-Eldridge syndrome. Now, another favorite question of your examiners is a classic, most common vasculitis in children. Here you have a child who comes to you with pain abdomen, arthritis, palpable purpura. Remember, Henault-Schönlein purpura is the most common vasculitis in children. Henault-Schönlein purpura, which is also called IgA vasculitis. Now we call it as IgA vasculitis. It is the most common small vessel vasculitis also in children. It is the most common, remember, vasculitis in which you see neutrophils within the arteriole wall. Okay. So remember, it's a classic case. And here I will show you the typical criteria by the American College of Rheumatology. So according to the American College of Rheumatology, everyone, you need to have two of the following criteria: palpable purpura, onset less than 20 years, bowel angina. So remember that they can have pain abdomen, bloody diarrhea. So in the last year's NEETPG, there was a child who had bloody diarrhea. So remember, because of the mesenteric ischemia, these children can have pain abdomen, bloody diarrhea. Okay. And it's a vasculitis. Leukocytoclastic. Leukocytoclastic matlab neutrophils are in the wall of the arterioles or venules. Now remember, kidney is involved in almost 50% of them, where you will see nephritis. So some RBCs in the urine, so microscopic hematuria, proteinuria may be seen in the walls of the arterioles or venules. So in kidney, mostly it's microscopic hematuria or proteinuria. Okay, so kidney mein you see HSP nephritis. Now, the last question here is of a metabolic disorder, a baby who comes to you who has a high ammonia. So remember, all of you, whenever a patient comes to you with unexplained, say a baby comes to you with unexplained coma. Now, in the middle of the night, all of you, you do 3 tests. If you have a baby who is not having so today we did not talk about infections. We told you if a baby is sick, in the first week, it could be heart disease. And now I will say it can also be a metabolic disorder if it is not infections. So in the middle of the night, everyone, we do 3 tests. These are readily available in our hospital. We look at the ammonia, the blood pH, and ketones. So if ammonia is high and pH is actually slightly, they have respiratory alkalosis. Think about urea cycle disorder. Ammonia is high. There is in fact respiratory alkalosis. Think about urea cycle disorder. Okay. And remember, all of you, the most common urea cycle disorder is the typical X-linked dominant OTC deficiency. The most common urea cycle disorder. Common in boys. And remember, they have urinary orotic acid urea. So remember, urinary orotic acid urea, which gives rise to uracil in the urine. Urine uracil, urine orotic acid urea is classic of the most common urea cycle disorder called OTC deficiency. Okay. Now suppose ammonia is high, but there is metabolic acidosis. Then you look for whether there is ketosis or not. Okay. Because if there is no ketosis, it's a fatty acid oxidation defect. So remember, if there is no ketosis, it's a fatty acid oxidation defect. But if there is ketosis, it can be an organic acidemia or a mitochondrial disorder. So if there is ketosis, it can be an organic acidemia or a mitochondrial disorder. Okay. Now remember a very important question. Organic acidemia with a rash. Think about multiple carboxylase deficiency. Organic acidemia with a rash. Think about multiple carboxylase deficiency. Okay. Organic acidemia with a rash, multiple carboxylase deficiency, for which the drug of choice is biotin.